Okay, good morning everyone. I'm quickly going to cover pharmacology, mode of action and licensing. Basically the pharmacology, I'm going to go through how the product affects the cells. The mode of action, we'll look at sclerotherapy itself at the level of the treated vein. And then we're going to go over the history of foam, where we are now, and some of the things we're doing going forward. So for pharmacology, basically have a quick look at what Fibrovein is, how it works, why it's safe in practice, and the conclusions. So Fibrovein, as Philip's already mentioned, the active ingredient is a product called sodium tetradecyl sulfates. And it's a strong detergent, and so is polydocanol. So basically the two sclerosants on the market are strong detergents. And detergent molecules basically have a water-loving head and a water-phobic tail. So what happens is when they're in solution, they form what are called myceles. So what's a mycele? So basically, the molecules aggregate into little groups, into spheres or tubes, because the water-phobic tails hide inwards away from the solution, and the water-loving heads sit on the outside, and they create these stable structures. And because the interior of the mycele is very water-phobic, it's got the ability to suck in or sequester other water-phobic molecules, things like oils, proteins, and fats. And then the oils and proteins and fats get encapsulated in the myceles, emulsified and dispersed in the solution. And basically it's how washing up liquid works. So my favourite story is myceles partly depends on temperature. So after you've had your curry of an evening, Friday evening, and you wash up all your plates, and you forget to tip out all the fats emulsified, but when you come back in the morning and everything's cooled down, the myceles are broken down, all the fats come out, and it all sits on the surface. So that's what's going on. It's basically down to the mycelar structure. So, but how does STS affect the cell? Well, quite easily. A cell membrane is a phospholipid bilayer. Water-loving heads on the outside, lipid layer on the inside. So when you inject your sclerosant into the vein, when it hits the vein wall, it basically does what your washing up liquid does, and it sucks some of the membrane proteins, and it destroys the membrane by sequestering the cell wall. As a result, the myceles form complexes with the lipids and proteins. So as it binds with blood proteins, cell proteins, the wall proteins, the drug product becomes deactivated, as Philip mentioned earlier. So in conclusion, the STS only acts locally by disrupting the cell wall. Any excess STS is quickly deactivated by blood and cell proteins, which has been shown by some nice work by Koresh Parsi in Australia. It takes a surprisingly small amount of blood to deactivate the sclerosant. We did some work in the lab, and it only takes 0.5 ml of whole blood to deactivate 1 ml of liquid 3% STS. So it's unsurprising that the old liquid treatments didn't work. The blood is just killing it. And 2 papers have shown that there's no active sclerosant circulating the bloodstream. So it basically shows that the action's very local, and once it's moved away from the injection site, it's deactivated very quickly. And I think as we go on, you'll see this is why Andrew and Philip have developed their technique. The old BTG technique with Varisolve, the Cabrera technique, was to cannulate below the knee and try and pump in quite high volumes of sclerosant foam and push it up the leg vein. So it looked great on ultrasound because you could see bubbles up near the junction, the top of the GSV, but you were probably only seeing bubbles in blood and the sclerosant was deactivated. The European technique and the technique that Philip and Andrew have developed over time is to have more injection points. So I think one of the keys to success with foam is more injection points and small doses of fresh foam. And this is the reason, because it's deactivated very quickly. So moving on to the mode of action. Okay, we're going to have a quick look at what's the aim of sclerotherapy, what happens, importantly, what doesn't happen, and some conclusions. So the aim of sclerotherapy basically is to produce maximum endothelial damage, leading to a small thrombus formation and ultimately that leads to fibrosis of that treated vein section. So what happens to the fibrovein foam? As Philip showed, you inject it into the vein, the foam displaces the blood, the sclerosant is then able to destroy the endothelium by destroying the cell wall. There's also evidence that the sclerosant, particularly STS, damages the vein wall. Mark Whiteley's group have just recently done some work on that. But most of the damage is to the endothelium itself. What happens next? Basically, you've got damaged cells, you've got exposed collagen fibers of the vein wall. These initiate the local clotting pathways and inflammation response. The vein goes into spasm, and basically the next bit of blood that comes down the vein, it's like if you cut yourself, forms a very hard sclerothrombus. So I tend to talk about a sclerothrombus to distinguish it from a soft thrombus. Following sclerosant damage, the thrombus is very hard and firmly attached to the vein wall. It's going nowhere, as opposed to like a soft DVT type thrombus. So basically you've got this sclerothrombus, it's very hard, it's firmly attached to the damaged vein wall, if all's gone well. The body just responds, fibroblasts infiltrate the thrombus, it's slowly reorganized, eventually forming a thin fibrous cord, and the result is total obliteration of the vein, and in time it's reabsorbed. And those of you who've done foam, sometimes at 12 months you can't even find the GSV or the vein that you've treated, it's just been reabsorbed, or there's a very small fibrous cord. What doesn't happen? Fibrovein doesn't cause the blood to clot. Some people who don't really understand the process think the sclerosant causes a clot in the vein. It doesn't. It's the damage to the vein, the endothelium and the vein wall. And there have been some experiments. George Fegan back in the 60s did some experiments, and Kourosh Parsi in Australia has done some more recently. And they've both shown that STS is actually non-thrombogenic and will prevent blood clotting in vitro. So the STS is not causing any blood clots at all. It's all down to the local damage. So conclusions, basically the sclerosant damages the endothelium of the vein, and it's a local action. That initiates the clotting pathways. And any excess STS is deactivated by the blood proteins, so it's not causing any damage elsewhere in the body. Okay, moving on to the licensing. I'm going to go over the history of foam in a little bit more detail. Philip just covered it briefly. We'll look at where foam has a license, conclusions of the licensing, and then what we're doing going forward. So as Philip said, people were sort of playing around with foam for years and years and years, but the proper use really started in 1995 with Juan Cabrera in Spain, where he published his first paper. As Philip showed the photos, they were making foam using polydocanol, and I thought it was quite sophisticated, but it looked like a Dremel with a whisk on the ends. But importantly, Juan Cabrera published some clinical data showing the treatment of saphenous veins, venous malformations using high volumes of foam and getting great success. He's also quite a shrewd operator. I think he still is quite a shrewd operator. And he patented his technique. And the patents and the rights were bought up by a company called BTG. So BTG developed foam in a can, as I like to call it, or Varisolve. And they started doing trials in the UK and Europe. And this is where people like Philip and Andrew got involved and got introduced to foam sclerotherapy, realized it worked. But the problem was, if you couldn't have foam in a can because it belonged to BTG and it was patented, how could you make foam? Well, in 2000, Italian surgeon Lorenzo Tessari was the first to describe another way of making foam using a standard sclerosant and air. In 2001, 2002, the first clinical data for Tessari foam was published by Lorenzo, Attilio Cavezzi, Alessandro Frellini, and they were getting good results. And as a result, the Tessari technique with just your bog standard sclerosant, whoosh it between two syringes and a three-way tap, was adopted across Europe, Australia, and the USA. So it's quickly adopted and being used a lot. So what happened from 2002 onwards, BTG were investing heavily in their Varisolve trial in Europe, but especially in America. There were clinical papers, Andrew, Philip, the Italians, the Australians, everyone was publishing papers, clinical papers, on the results with Tesari foam using both STS and polydocanol. But the problem was Tesari foam was in widespread use, but it wasn't licensed. We hadn't got it on our license. Kreuzler in Germany hadn't got it on their license. BTG hadn't got their license either. So we were all working pretty hard. So it's pretty safe to say the race was on to see who could get there first. In true to form, the Germans were the first around the pool. So Kreuzler got foam on their etoxysclerol license in 2009. That was followed shortly. 2 years later, they got foam on the license in Austria. In 2012, we got foam onto the Fibrovein license here in France, Spain, Portugal, and Czech Republic for the 3% and 1%. 2013, Kreuzler added some more countries to the etoxysclerol license, so they got France, Sweden, Holland, Belarus, and the Ukraine. So this table is a summary of the homemade licenses. So for us, 3 and 1%, we've got foam on the license in 5 countries. Etoxy have got foam on the license for their higher strengths in 7 countries. And the maximum doses are approximately similar, around about 16 mil. Whereas I think the original BTG max dose was something like 60 mil, which is enough to fill a whole person, I think. Yeah, I think it cured everything. So the thing to take away from that is 11 countries have assessed the safety and efficacy of homemade foam with air and approved its use. There's some scaremongering in certain parts. There have been published cases of stroke-like symptoms, TIAs. I think at the moment there have been 13 published cases, and there's a nice review article by Kourosh Parsi in Australia. When we were getting foam added to the license, I had to write a risk management plan and argue the safety aspect with the regulatory authorities. And to put it into perspective, we conservatively estimate since 2002, there are about 1 million foam treatments worldwide a year. So in that period, we've had 13 published cases of temporary stroke-like symptoms in approximately 10 million patient exposures. So we think it's pretty safe. And most of those, when they're assessed, I think 2/3 of them have had a PFO. So if you take PFO, patients with a PFO out of the equation, foam sclerotherapy is very safe. Foam in a can got its license last year, and as Philip said, it got changed to Varithena. It's quite expensive. Your foam in a can is going to cost you $2,500 to $3,000, which, bearing in mind, BTG spent $200 million getting it approved. And you get about 45 mil of foam out of it, so you're looking at about $500 a treatment. So we'll wait and see how successful that is in America. And again, the dosage came down. Their approved max dosage is 15 mil. So in conclusion, foam's been assessed, the safety and efficacy has been assessed in 12 countries, and it's got a license. More importantly for us, the homemade foam has been assessed in 11 countries and passed. The maximum doses, contraindications, warnings, and adverse events are all similar. So you're now licensed to foam. Going forward, as part of the approval, we've been given what are called post-authorization commitments. Okay, one of which is a post-authorization safety study. And the study is really, it's an observational study. When we wrote the SPC, we're putting out, on SPCs, you have the frequency of adverse reactions. So obviously we're giving it our best guess based on publications. What the regulatory bodies have asked us to do is to do a big observational study to try and assess to see whether we're correct and then adjust the SPC as required. So Andrew's looking after that. So if anyone's interested in taking part in that, please see Andrew. Thank you.